Yeah, sure. So we're going to be talking about a project that we worked on or working on forecasting emergency admissions for operational use in the NHS. My name is Jane. I work as a data science analyst. I'm going to talk today about kind of the context for the project and then also some of the kind of thinking behind the modelling technique that we used for forecasting.
And I'm Lizzie Johnstone. I'm a data scientist in the same team, and I'm going to be speaking about the modelling approach.
Okay, so this is just like a little bit about our team, so like where we sit in the NHS. So we work for NHS England, and in that we work in the data and analytics bit. And our team is called the Economic and Strategic Analysis team. We work on a number of different projects across the NHS, and people on our team are kind of a mixture of people from different analytical backgrounds. This is the data science bit of the team. So yeah, just I suppose to think about like why do we want to forecast people who are entering hospital through emergency departments, and then just some of the requirements for the model. So the recovery of elective services, so of planned care for people, is a really big priority for the NHS, particularly in the back of because of the COVID pandemic. The ability to deliver planned care for people, so things like surgery and stuff like that, is impacted by how much unplanned care you have to deliver. And I suppose one of the things that impacts that a lot is hospital admissions coming through emergency departments. So that's kind of the context in which we're looking at forecasting emergency department admissions to provide some intelligence on that to support with, I suppose, like planning across the hospital, and particularly in terms of delivering elective planned care for people. So our objectives are to, for this project, was to develop a forecasting tool that would support local decision makers with planning of things like staff and beds and where to put resources. The output of our work are daily 21-day ahead forecasts of emergency admissions. So in a particular trust, how many people are forecasted to be admitted to hospital through A&E. This project was done in like a co-development team with Faculty AI, who are like, I suppose, an artificial intelligence, like insight-driven consultant, although they've now rolled off the project and it's being developed within our team in NHS England. So this is just to think about, kind of the things that we were thinking about when we started out to forecast emergency department admissions. We needed some data about people who were being admitted to hospital, and so we're using ECDS, the emergency care data set, which is like a patient level data set about people who go to A&E. There are some good things about this, and I suppose why we chose to use it. So it's updated daily. The person levelness of it means that there's good granularity and scope for model enhancements. Although at the moment we use like an aggregate number, so for a particular trust, how many people were admitted in a day, that's kind of what the model's fed. So it's not being used in like a person level at the moment, but that gives us scope that's available. It is a newer data set and there are some data quality issues, particularly like back when it started. Those are alleviated through other data sources, so we also use admitted patient care data as well. We wanted to have our forecast as accurate as possible. I don't know. I don't think anyone sets out to create inaccurate forecasts, but the context of this work was, to support clinicians with decision making. So that was something we were bearing in mind when selecting the forecasting technique. The model outputs forecasts every day for 122 NHS trusts, which is the vast majority of NHS trusts with the type 1 thing. So we needed like a way of getting that to people. So the model outputs are displayed on a dashboard, which is updated daily. And then another important consideration, maybe particularly with the context that this model was being used in, was that it was explainable. So to help users of the tool understand and trust and use the forecast, I suppose, in an appropriate way, we look to be able to choose a model where the features, so the things that like go into the model to make the predictions, so this is going to talk more about in a few minutes, that they can be easily explained by people, easily understood by people, so that they can go on to make decisions from the children forecasts.
Thank you. Great. Now I'll now speak about the modelling approach. So we use a Bayesian hierarchical modelling approach. So that comprises of 3 parts. So the first part is Bayesian. This allows us to bring together prior information. So that's like assumptions, our assumptions on what we think the model is going to be like, and to combine that with real, true historical data from the trusts. And combining those two together, we're able to provide estimates on what we think the forecast is going to be. It also allows us to give confidence limits. So we can say within 95% confidence or within 80% confidence, we think that the data is going to fall within these limits. The second part is hierarchical. This allows for the trusts to share information across each other. So in some cases with the ECDS data, we don't necessarily have great data quality for some trusts, or there might be cases where there's missing data. But using hierarchical allows us to share information across similar trusts. At the moment, we do this based on the size of the trust, but there is potential that we could do this in separate groups as well. The third part is modelling. So this is using, the way that we model is we use a component breakdown. So the best way to describe this is kind of like using building blocks. And by using building blocks, this means that we have a lot of control over the model that we use. And it also means that the model's really explainable. So more on the explainability, I'll explain the blocks that we use. So we use 6 different blocks at the moment. The first one is general trend. So this explains things like, for a trust, how many admissions come through? Or over time, are the admissions increasing or are they decreasing? Or has something happened in that trust, such as a merger? Secondly, we've got weekly seasonality. So this can explain things like working hours and patient behaviour throughout a week. It can also explain things like hospital opening times. Similarly, we look at yearly seasonality. So this can explain things like we see over winter periods that more admissions can come through, and we can use that information from historical periods to help forecast forwards for future periods. Things that can explain this yearly seasonality can include things like pollen counts and holiday seasons, patient behaviour over different seasons. Another that we use is bank holidays. So we've seen that there's a significant drop in admissions on certain bank holidays, such as Christmas. And we know when the next Christmas is going to be. We know when the next bank holidays are going to be. So we can use previous bank holidays to forecast forwards on the behaviour that's happened before. And the next 2 that we've got are leading indicators. So this is where we look at patterns with certain indicators. So we use COVID and weather. So with weather, it's temperature. And where we've seen patterns between admissions and temperature, or between admissions and COVID, we've then used COVID and weather forecasts to say, okay, if we know that it's going to be hot next week, that can give us a bit of information on what the admissions might be doing as well. We're really excited with the results of our forecast. So we've measured this in comparison to a simple model, a naive model. And the difference that we've seen is that the mean absolute error, which is on average how far away is our true value from our forecasted value, and that's improved from 23 admissions to 11 admissions. The number of times that the admission falls within 10 values between the true value and the forecasted value has gone up from 33% to 60%. And the percentage of times that the forecast fell within the true value has increased from 15 to 28%, which is almost double. The model is online and it's available to over 122 NHS trusts across all 7 NHS regions. We've got 1,200 users, more, and that's across operational decision makers, clinical staff, and strategic decision makers as well. One of the advantages that we found with our tool as well is that it's allowed for incentive for trusts to improve their data quality in the ECDS data. And that's where trusts have reached out to us and said, this isn't looking like what we're seeing in a hospital. Can you explain to us why these figures don't match? And we've been able to get back to them and explain where we're seeing that disparity. We've had some really good feedback. I'll just leave that on the screen. I'll not talk through it. And in general, we're just really excited by the model and the scope of what its potential is as well. If you would like access to the dashboard, we have an email address here. Please feel free to contact us and we'll try and work out access. And I think we've got a couple minutes for questions.
Thank you, yes.